Hello, I'm Fergus Shanahan and welcome back to The Language of Illness, a series of brief presentations based on my book of the same name, published by Liberties Press. In prior episodes, we've looked at the language of the doctor and the language of the patient. In this episode, we will address public health messaging. Pandemics, including the recent COVID-19 crisis, has shown how personal and public health are interconnected. Individual safety is dependent on the behaviour of others. Changing public behaviour has never been easy. It requires leadership with clear, consistent messaging. If the messages are mixed or inconsistent, public trust is lost and anger takes its place. Misuse of language and misunderstandings abound in many areas of public health messaging. Major non-COVID public health challenges of our time have been confounded by mixed messaging and confused policy. A recent example was the failure of health authorities and the media to explain the distinction between screening and diagnosis of disease. This confused public debate and undermined confidence in many screening programs. Simply stated, if you have symptoms, you need a diagnosis, not screening. Screening is for people who have not yet developed symptoms of disease. It's not about diagnosing people who are ill. Long before COVID-19, the increasing resistance of bacteria to antibiotics, along with a diminishing pipeline of effective new antibiotics, was declared a public health emergency. But how many people knew this? Control measures have been feeble, in part because the language used to describe the problem is unclear and lacks urgency. Surveys have revealed remarkable misconceptions among the public, many of whom think it is the person rather than the infecting organism which becomes resistant. Furthermore, the lack of urgency of public health messages regarding antimicrobial resistance is shown by the failure to clarify that antimicrobial resistance may be highly contagious and spreads from patient to patient in overcrowded, poorly designed hospitals. If the infectious nature of the problem were explicit, the threat to everyone would be appreciated and the response more urgent. Flawed language also contributes to the ineffectual campaigns addressing other public health dilemmas. In some cases, public health ventures have reinforced rather than reduced the stigmatizing effect of illness. For example, bias against people who are overweight is widespread throughout society, including the health service, and patients are reluctant to attend medical appointments when they feel stigmatized by a doctor's language. No one should be defined by their illness. As one of the biggest health problems in society, one might anticipate that obesity would be tackled with a concerted, well-planned, multifaceted strategy for management and prevention. Not so. Instead, there has been a stream of mixed signals, misleading messages, incoherent policies, and siloed thinking. At a simplistic level, overweight and obesity have been framed as a discrepancy between energy or caloric intake and expenditure by exercise. In other words, it's the patient's fault. Overconsumption and sloth. Eat less and move more is the simple solution. This leaves the individual stigmatized and guilt-laden. However, the energy in, energy out formula for weight regulation is only a half-truth and a huge oversimplification that fails to take into account individual susceptibilities, food policies, and obesogenic environments and lifestyles, such as widespread use of energy-dense processed foods, reduction in home cooking, growth in consumption of fast foods, the increasing popularity of eating out in restaurants, and reduced physical activity. In many cases, the obesogenic exposure begins in childhood and is beyond the control of an innocent child. Finally, for those of us hoping for an endgame to COVID-19, the Anti-Vaccine Lobby is another public health threat that needs to be tackled with careful messaging. The problem is confounded by misinformation. An infodemic is how the World Health Organization described the challenge. The infodemic accompanying the pandemic is a flood of information which needs proper interpretation and disinformation which needs to be fought. Trying to convince vaccine deniers of the safety and effectiveness of immunisation is like trying to debate with conspiracy theorists, flat earth enthusiasts, and those who insist that Elvis is still alive. Logic, science, and repeated medical assurance of safety seldom shift their opinion. Facts don't work, but people's stories might. Research with other infections, such as measles, shows that real stories of what happens when vulnerable people become infected may have some impact on vaccine hesitancy. Public health narratives need to convey the message that public health only works for the individual if it is a collective enterprise, and fears of vaccines need to be supplemented and supplanted by real messages of what happens to real people when real diseases are allowed to spread. That's it for this episode. Join me next time on The Language of Illness when we look at a different aspect of the entire topic of how patients interact with their carers.